Day 2 of our class at My Health Hospital. This is regarding what did we discuss in first class? Day 1 we have discussed about assessing the critical patients. Day 2, the second class, we are here discussing about lines, interventions, different sizes of the interventions that we regularly use in hospitals, especially in super specialty center. This class is only to brush up your knowledge and all the things that you already know. So this is not a one way of making you understand things. This is about teaching in coordination, what you know and what you want to listen, and where we shouldn't make any mistakes. Brief ga, how many of you are aware of the interventions? Interventions ante enti? What are the interventions that we do in hospitals? What do you mean by interventions? What are non-interventions? Interventions. Rise tube is an intervention. Huh? Invasive lines. Interventions are invasive lines. Interventions are all invasive lines. So, Foley's catheter is an intervention. Okay. ET tube is intervention. Intubation is intervention. Central is intervention. What is non-intervention? Very good. Oxygen support is non-invasive. Inka? Scannings, X-rays, all lab things, whatever you get, are all non-invasive. Endoscopy is invasive or interventional? What is? This is invasive, interventional or what? Good. So this part we are clear. So let's start with Ryle's tube. What is a Ryle's tube? What is the purpose of a Ryle's tube? Ryle's tube used into. How do you identify Ryle's tube? Ryle's tube length enta and ekkadekada vaartam. Ryle's tube is to drain what? Ryle's tube ఏమంటారు? Ryle's tube is nasogastric tube. What do you mean by nasogastric tube? What do you mean by nasogastric tube? To give in? No. Nasogastric tube. అంటే అర్థం ఏంటి? Nasogastric tube అంటే meaning through nose to stomach. ఓకే. ఐడియల్ లెంత్ ఎంత? దీని యూజ్ ఏంటి? ఇండికేషన్స్ ఏంటివి? వాట్ ఆర్ ద ఇండికేషన్స్? ఎప్పుడు వాడతాము? ఏం చేస్తాం? వాళ్ళకి ఇస్తాం. పర్పస్ ఏంటి? సో ఫార్మసీ ఓటీ పీపుల్ హ్యావ్ సెడ్ దట్ విల్ ఆస్క్ ఫార్మసీ పీపుల్, Reshma, how will you identify Ryle's tube? Without seeing the name, how will you see if this is a Ryle's tube or not? इसको देख के Ryle's tube बोल के कैसे बोलते हैं? Anyone? Identification, देने specimen identification. So, all Ryle's tube length is 100 centimeters. The entire length we calculate from tip to tip. This green tip to green tip. దీంట్లో ఎఫెక్టివ్ లెంత్ మనకు వచ్చేసి సమ్ పార్ట్ ఈస్ వేస్టెడ్, వీ హ్యావ్ టు కీప్ ఇట్ అవుట్ ఆఫ్ ది నోస్, యాంకర్ ఇట్ కాబట్టి దట్ ఈస్ లాస్ట్ కాబట్టి ఎఫెక్టివ్ యూజ్ ఇస్ అరౌండ్ 90 సెంటీమీటర్స్. అందులో ఇంకోటి కూడా Ryle's tube will have a single lumen tube. What do we have at the end of the Ryle's tube? End of the Ryle's tube ఏముంటుంది? హోల్స్ ఉంటాయి. సో దిస్ ఇస్ హౌ యూ ఐడెంటిఫై a Ryle's tube. Okay, a single lumen tube with a cap, feeding cap, the draining tip end with a radio opaque material, and it has multiple openings at the distal అంటే చివరి భాగంలో ఓపెనింగ్స్ ఉంటాయి. ఈ ఓపెనింగ్స్ ఎందుకు? ఫీడ్ వేసినప్పుడు పోవడానికి. ఇంకా ఓకే ఇంకా ఆస్పిరేషన్స్ కి. వెరీ గుడ్. సో ఇది దట్స్ వన్ థింగ్. రెండోది, ఇఫ్ యూ గైస్ కెన్ సీ, దిస్ ఈస్ వాట్ గ్రీన్ లైన్. ఈ డిజైన్ ఎందుకు ఇచ్చాడు? మార్కెట్లో కొత్త డిజైన్ ఎందుకు ఇచ్చాడు? ఈ కంపెనీకే స్పెసిఫిక్గా అన్నిటికీ ఉంటుందా? ఎందుకు ఉంటుంది లైన్? హ్యావ్ యు ఎవర్ థాట్? సైన్స్ అంటేనే ప్రశ్నించుకోవాలి. This is radio marker to identify on X-rays whether it is there or not in the desired cavity. So Ryle's tube, when we place it, X-ray లో చూస్తూ ఉంటే మనకి X-ray చూస్తే మధ్యలో టిప్ లో యూ ఫైండ్ ఇట్ ఇక్కడ ఉంది అని చెప్పేసి. బట్ ద ఎంటైర్ పార్ట్ ఇన్ ద లూమెన్ వెదర్ ఇట్ ఇస్ ఇన్ యూసోఫేగస్ ఆర్ నాట్, వెదర్ హౌ ఇస్ ఇట్ పాసింగ్, హౌ ఇస్ ఇన్ ద స్టమక్, అవన్నీ తెలుసుకోవాలి అంటే హౌ డు యూ సీ ఇట్ విల్ గో త్రూ దట్ పార్ట్. సో ద ఎంటైర్ థింగ్ ఈస్ విజిబుల్ ఇన్ X-ray. యూ డోంట్ హ్యావ్ టు గివ్ కాంట్రాస్ట్. ఓకే. రెండోది, सबसे ज्यादा कंफ्यूजन किससे होता है? Ryle's tube. And what is the common other line that we get confused with? Suction tube. In the suction catheter, how will it look? How do you identify a suction tube? How do you differentiate suction tube from the Ryle's tube?
Suction catheter slide with
tip is open. అవును, దానికి మరి దీనికి కూడా టిప్ గిడ పెట్టుకోవచ్చు, లేకుంటే దానికి కూడా సైడ్ పెట్టొచ్చు కదా. మరి వాడు ఎందుకు ఇట్లా ఇచ్చాడు? యూఆర్ గెటింగ్ ఇట్. అందులో కూడా డిస్టెన్షన్ వస్తుంది. కమాన్ కమాన్ కమాన్, ఆడెవడో వైభవ్ ఉన్నాడు, వాడిని ఎక్స్ప్రెషన్ చేయాల్సి వస్తుంది. సి సక్షన్, ద టిప్ ఈజ్ ఓపెన్. వెన్ యూ కనెక్టెడ్ టు అ సక్షన్ మెషిన్, ఇట్ గెట్స్ సక్ ద స్టమక్ మ్యూకస్ ఆర్ వాట్ ఎవర్ మ్యూకస్ ప్లగ్ ఇక్కడ నుంచి వచ్చింది. వెన్ యూ డూ సక్షన్, where do we suction? Oral secretions కానీ laryngeal airway obstructions sections అక్కడ చేస్తాం. So when we do that, we need to have an end point suction, not at the edges. The effective suction, if some mucus plug is there, if we are sucking it here, we need impact here. We don't want here. So ఇక్కడ ఉందనుకో, it won't catch until and unless all the holes are inside. The Ryle's tube can't do effective suction. Okay? Reshma? सक्शन ट्यूब बिना अगर ये नाम देख के सब पता चलेंगे, मगर इसको देख के पता चलना चाहिए कि क्या है. सक्शन ट्यूब टिप का रहेगा, इसका उसको कैप रहेगा, सक्शन को कैप रहेगा, ढक्कन रहेगा. नो, वी डोंट हैव ए कैप. इट्स एन ओपन थिंग, स्ट्राइट वन, लेंथ इज शॉर्ट. ओके. Ryle's tube sizes. Okay, so which is the biggest size? 1820. Colors?
white, grey, orange, black.
Red, blue, yellow, maroon, pink. అని చెప్పండి, అది కాదు. సైజ్, కలర్. వీళ్ళు ఏం చెప్తారు? ఈ నూరు కూడా తెలుస్తున్నాడు. నేను పెట్టుకున్నావు ఏంది కింద పుట్టినాలేమో, బెల్లం పుట్టినాలు నోట్లు వేసుకొని వచ్చిన. చెప్పు, తెలుగు అమ్మేవాను మరి, చెప్పు. నువ్వు ఎన్ని రోజులు ఏం చేరి? చెప్పు, ఏం చేస్తా చెప్పు. ఏంటి ఏం చెప్తాను? సైజ్ చెప్పు. ఇదే సైజ్, ఇది గ్రీన్. వెరీ గుడ్. 16 का कौन सा कलर है? वेरी गुड. 18 का ठीक है. चलो, so this color holds true for every, what do you call this, PVC lines. Okay, for all lines this holds true. Antena Rukmini, antena? Sorry, done. So that ends the chapter. Where do we use it? Indications ఏంటి, ఎక్కడెక్కడ వాడతాం? ఎవరు చెప్తారు దేని గురించి? ఎవరు చెప్తారు? సుజాన్ బోలో. పక్కకు చూస్తే అడగరు అనుకోవద్దు, చెప్పు. మీకు లాస్ట్ టైం వచ్చిన క్లాస్కి వచ్చిన వాళ్ళు ఎవరు రానప్పుడు అర్థం కావాలి. For feeding in whom? Unconscious patients, bedridden patients who can't swallow, unable to swallow patients, or normal patients లో ఎప్పుడు వేస్తాము? డిస్టెన్షన్. డిఎంఓలు ఏం చేస్తున్నారు? ఆయుషాన్ చెప్పండి మా, చెప్పండి. ఓపీ సిస్టర్ నుంచి ఎక్స్పెక్ట్ చేయొచ్చా, చేయకూడదా? సరే, ఓకే, పర్లేదు, మీరు చెప్పండి. నార్మల్ ఇంకెక్కడ వేస్తాం మనం? రెగ్యులర్ ఏమో సపోర్ట్ చేయాలి, చెప్పు. వెరీ గుడ్. పాయిజన్ కేసులో, అది పాయిజన్ లో ఏం చేస్తాము? ఏ కేసులలో చేయకూడదు? ఎందుకు? హ్యాంగ్ కేసులో ముట్టుకోకూడదు. అయితే సో within immediate గా చేయగలిగితే బెటర్. If it is past 6 hours, 8 hours or 24 hours, better not to do anything. Don't put a Ryle's tube. Okay, sorry, fine. And the actual purpose of Ryle's tube is in emergency situations for stomach wash, poisoning cases, for lavage, washing, stomach washing. In elective scenarios for feeding. In patients who are other patients where we need to do it anante, like in stomach decompression, when the patient is posted for procedures, upper abdominal surgery posted in a patient's ki, we will do a will place a Ryle's tube. What is the ideal number of the Ryle's tube for feeding? 14 is not preferred. 16. 14 is too small. If you give something, the pores will get clogged, and day 3, day 4, it will you can't feed him. So you have to push. There will be a lot of resistance. So 16 is ideal. And for surgical patients, stomach decompression key, what is the you can use 14. What is the other material? What is this material made of? This is not silicone. ఏంది? No, కాదు, ఇది PVC. And the other material that we use is silicone. Silicone, what is the advantage of using a silicone? Long patience ఉండే వాళ్ళకి ఎందుకు? No, ప్రెషర్ నెక్రోసిస్ అవుతూ ఉంటుంది వాళ్ళకి. ప్రెషర్ నెక్రోసిస్ కాకుండా ఉండడానికి we use that, which is softer, goes easy, patient tolerance level will be better with silicone. What is the disadvantage of silicone Ryle's tube? Advantage okay, అన్నిటికీ లాభం ఉంటుంది, నష్టం ఉంటుంది. దాంతో బ్యాడ్ పాయింట్ ఏంటి? If it is soft, it is difficult to technically challenging. Okay, right. Decompression చెప్పాను. In some cases we can use it as drain. In some cases we can use it for decompression, elective decompression, food poisoning, feeding. For ఏ సర్జరీలో ఆ డ్రైన్లో కాకుండా వేరే కాడ పెడతాం. వేర్ ఎల్స్ విల్ కీప్ దిస్? సరే, ఈరోజు మాకు లేకపోతే డ్రైన్కి కాకుండా అంటున్నాం. సో దిస్ ఈజ్ యువర్ క్వశ్చన్. ఎవరు ఫస్ట్ చెప్తే they'll have a surprise gift. Apart from drain, apart from inserting in the stomach, where do you for చెప్పు. ఓకే, కొన్నిసార్లు వాల్వులస్ డీకంప్రెషన్ కి ఫర్ ఎమర్జెన్సీ పర్పస్ యూ కెన్ యూజ్ దిస్. దట్స్ ఓకే. నో, ఇంకా చెప్పు, సిగ్గుపడదు. క్యాన్సర్ పేషెంట్స్ ఏమన్నావు? ఏం చేస్తావు? చేస్తే యూసోఫికస్కి అయితే ఏం చేస్తావు? నేను గెలుచుకున్నారా గిఫ్ట్ తెలియకలో చెప్పాను కదా. లేదా ఫీడింగ్ జెజనోస్టమీ, the only procedure where you place into the intestine directly, open up and place it intestine directly. Okay, MCET లో ఇంపార్టెంట్ బిట్, అది మర్చిపోకూడదు. నెక్స్ట్, మనం అందరం కామన్ గా చేసే మిస్టేక్, మోస్ట్ కామన్ మిస్టేక్, 90% of us, what we do, we will place a Ryle's tube. One more indication is before CPAP పెట్టేటప్పుడు Ryle's tube insert చేస్తాం. Why do we use before using CPAP ICU? కంటిన్యూస్ ఆస్పిరేషన్. కానీ మనం ఏం చేస్తాం? అది కంటిన్యూస్ ఆస్పిరేషనే, కానీ మనం ఏం చేస్తాం? అలా చేస్తే కరెక్ట్, అలా చేయం. దీని ఇలా క్లాంప్ పెట్టేసి మనం CPAP పెడతాం. పేషెంట్ ఏం చేస్తాడు? ఆస్పిరేట్ చేసుకుంటాడు. ఎందుకు ఆస్పిరేట్ చేసుకుంటాడు? నువ్వు కూడా ఐసీ కదా, చెప్పు, ఎందుకు ఆస్పిరేట్ చేసుకుంటాడు? Why will they aspirate is because when CPAP pushes, or BiPAP or CPAP pushes air, it goes into the 1/3 of the air also goes into the stomach, because it is more easy way to go there. patient has to take synchronous breathe చేయకోకుండా ఉన్నప్పుడు it will push it into the stomach as well. So what happens, stomach will get bloated. When the stomach gets bloated, already a sick patient, he will burp it or he tends to aspirate. Aspiration ని ప్రివెంట్ చేయడానికి we keep a Ryle's tube and connect it to the bag. కానీ మనం ఏం చేస్తాము, బ్యాగ్ కనెక్ట్ చేయం, ఈ మూతను మూస్తాం, మనకి సీపాప్ వేస్తాం, వాడు ఆస్పిరేట్ చేసుకుంటాడు. తెల్లారి సాచురేషన్ డౌన్ అయింది, ఏమైంది, పిలవండి కోడ్ బ్లూ అని అంటే, నెవర్ డూ దిస్ మిస్టేక్. ఇఫ్ యు ఆర్ కనెక్టింగ్ ప్లేసింగ్ a Ryle's tube until unless it is said to be clamped, do not clamp a Ryle's tube. Okay, done. Then now that we have come to Ryle's tube, most common thing that we encounter is ఏంటిది, Foley's catheter. Use. How did you identify that it is a Foley's catheter? ये Foley से बोल के कैसे पता है? How do you know, रेशमा? Foley's catheter. इसमें क्या है? जो दिख रहा है वही है ना? Color, length, size varies again. It has 2 bulbs and the tip has holes. Ryle's tube की holes की दिन की difference ఏంటి? Ryle's tube की, if it is at 12 o'clock, the other hole is at 3, the other hole is at 6, the other hole is at 9. Max it has 3 holes, but this has 3 o'clock and 6 o'clock. And see. And what does it have? What does it have? So what does it have? What does it for? ఏముంటుంది దీంట్లో? what is this? What is the use of this thing? This one, bulb is to inflate. So Foley's has a bulb, it has, the length is shorter, the color is yellow, and again the sizes varies according to color. What is the size of this thing? ఎట్లా తెలుసు? కలర్ universal colors are okay na for these interventions. Indications, drainage. How do you Foley's और turf drainage दोनों में क्या फर्क है? What is the difference between it? अरुण 3 ఉంటుంది ఎందుకు? It has to go through continuous irrigation. One is irrigation, one is drainage, one is bulb to fix it in place. Okay, that is the major difference. And this also has same sizes as in Ryle's tube. Okay, inkemana anything any other thing apart from regular urine this thing, where else do you use this Foley's? Okay, tracheostomy suction ki, why do you use this thing? Very good. ఇంకో కడ, ఇది కూడా యూరిన్ డ్రైనేజ్ కే, కానీ we use it in another place. Where? SPCs. SPC is one more indication where surgical intervention uses it. Suprapubic cystostomy. ఇంతే, ఇందులో ఇంకేమైనా ఉన్నాయా? Where do you connect it to? What is this? Do you always have to connect to urometer? What is the indication of urometer? Hourly urine output calculate cheyadaniki surgical patients ki, ICU sick patients who are really sick, where output really matters, వాళ్ళకి we need to have this thing. CKD patients. Yeah. So anyway, wherever urine has to be monitored, input output has to be monitored, we need urometer. If not urometer, what do we connect? Urobag, where it's a daily output that we measure. Okay, na? Done. Antena? What other material do we have in Foley's? Silicone. Okay. What is this made up of? Rubber. This is rubber. Okay, made from Indian rubber. Hard ఉంటుంది. What other material we can get Foley's in? What other material? What other material? Silicon. Silicon is another material. For long term uses, we use silicon. What is the difference between a Foley's of 12 or 10 size and adult Foley's or 14, 16 size? What is the difference? What additional feature does it have? Stillet. Good. Good. We get a stillet in that. And what is the pressure that should be given inflated in? And what is the ideal liquid that we are supposed to push in? No, no. Sterile water. Distilled water, sterile water. Okay. Why not NS? So, burst gun. No. Once the balloon, once crystal forms, when we have to remove foliage, if we aspirate, the flow back cannot be done. So that becomes a headache to remove foliage. Alantappudu what we do? Ultrasound guided balloon ni burst chestam. Okay. Okay. That is with this thing. Next. Next, what else we have? Canvas తీసుకుందామా? Identify the size based on color. OP. Blue. Okay. ఏది చెప్పినావు? ఇదా? బ్లూ చెప్పినా ఓకే డన్. ఇంకా ఏది? 18. Very good. Awesome. Color. So where do we use? No, not yellow. Dindi. What is the commonly used cannula? Pink. So what? How do we? Where do we use it? Full form ఏంటి దీనిది? Catheter. ఎక్కడ వాడతాము? Peripheral lines. Only for peripheral lines. ఎక్కడ వాడతాం ఇంకా? జుగులార్ సెంట్రల్ లైన్ కి తీసుకుంటప్పుడు. ఏ జుగులార్? ఎక్స్టర్నల్ ఇంటర్నల్? ఇంటర్నల్ ఎందుకే? So we'll keep it aside. It's most approachable, easily approachable. We'll do that. Okay. So దీంట్లో what commonly used size is? Which is? Okay. Which is? Pink. So regular this thing. Where do we use? ఇది when we need to infuse large volume of fluid, we use this. Okay. ठीक है. Large volume fluids infuse చేయడానికి okay, burns, septic shock, trauma, RTA వీటిలలో when we don't find a cannula, immediate to fix it, we'll use a 22, right? At least we need some access, then stabilize and then do it. ఎందుకు? How does it matter? What are the sizes here? 22, 18. What does it mean? 18, 20, 22. Difference గా ఉంటుంది. So it is the caliber of the vein. It is the diameter of cannula, the maximum flow rate, drip rate that can go through IV axis. When we look into this thing, when we connect it to a, what do we connect it into? What do we connect into? IV set. So when you connect into IV set, the flow rate, if somebody is asking, I need 150 ml per hour. 150 ml per hour can be done with which one? So it can't be done with 22. ఎందుకు అంటే the caliber is slow. మనం ఎంత పుష్ చేసినా కానీ the maximum amount we can get it around 75 to max is 75 to push 100 ml if the caliber is good. Okay. But the maximum caliber that we can get through 18 of this thing is we can go to bolus. We can give 150 ml. That is delivered comfortably. Okay, that is the main reason. And smaller the lumen, higher the chances of Because the vein caliber is low, there is a higher chances of blockage, thrombophlebitis. The moment we give antibiotic, titrate antibiotic and give, it might get blockage easily. What is the ideal time to change IV cannula? 72. 72 is 3 days or
3 to
no,
5 days.
ade. Or what, where else you will change it? It needs to be changed when there is a blockage, when patient has thrombophlebitis, or when he has fever spikes where we don't find any other reason, or otherwise a healthy patient. In those patients we need to change the cannula. That 3 days doesn't hold true in all the time. Okay. 24 does, when we put a 24 cannula, what is the IV set that we use? What is it? How do you differentiate between pediatric and adult sets? It's a, it comes with drip set, IV drip set. What is a drip set? How do you, there? How many types of drip sets are there? Pediatric ఏంటి difference? Hmm? Okay, done. So that's with the IV drip set. Okay, that's it. Next, this is a central venous line which is not on the back side. You have three lumens where it is clearly seen. It has three these things, you know, yeah, ports. So these three things, how do you use them? What else do you have? Triple lumen low, a central line. How many other lumens we have? Single lumen central అంటే ఇదే పెట్టుకోవచ్చు. ఎందుకు పెడుతున్నారు? Triple lumen. What is the need for a triple lumen central line? When we have a double lumen, why do we need triple lumen? We have a we have cannula. Why do we need this? More sick patients, we need rapid infusions, we need a access to the central lines. We need a ఏంది ఏమంటారు దీన్ని సెంట్రల్ లైన్. దీన్ని ట్రిపుల్ lumen లో డబుల్ lumen లో what do we use? What do we use double lumen for? Dialysis sheet separate కదా. Double lumen, where do you use double lumen? See, patient who is coming with a IV cannula, from IV cannula we are going to central line. That itself says that the seriousness of the patient. So patient who requires more rigorous volume monitoring, patient who require infusions, patient who require inotrope support, and with a continuous flow rate, we use this thing double lumen. But what is it need for a triple lumen? What is the additional lumen that helps us? CVP, central venous pressure measure చేయడానికి. The other lumen is for measuring CVP. Okay, what is the need for a to measure CVP? One is for one lumen we also use for feed. One lumen we use for fluids push చేయడానికి. Okay, done. And then CVP measuring. Okay, then okay. How do you know this is ICD? You can. What is this? Huh? कैसे पता? How do you know? इसको ये है. इसका cousin क्या है? Drain दे लेना. So ये क्या है? What is this? What is this? Anyone? What is this? How do you differentiate all three? And what is this? ER. ఏంటిది? Chest drain. All these three are chest drains. It has a tail. Okay. Abdominal drain. Arun, how do you get abdominal drains? The most confusing part between a chest drain and abdominal drain is both of them look similar except for one point. ఇందులో ట్రోకర్ ఉందా? ఏంటిది? ఏం కన్ఫ్యూజ్ అవుతాం? ఏముంటుంది? This end is free. This end is free. When we have a abdominal drain, we don't have, we have the same hole, same lumen of caliber and everything, material and everything is the same, but we don't have, we have an open end on this side as well. For this abdominal drain, we'll get a connector. Okay, okay, that is the difference between a chest drain and an abdominal drain. Abdominal drain is open on both sides. Chest drain is closed on one side. Why it is closed on one side? Because when we keep it in the lungs, intrathoracic pressure might come out. So we need to have it closed. Once it is connected, sealed, then connected to connector. Okay, fine. So to let not the intrathoracic pressure escape. So what is the difference between this one and this one? Chest drain. Trocar. Chest drain with trocar. So this we are using we are using nowadays and more frequently. It minimizes the chances of multiple more painful or more radical approach. This is easy to administer and easy to insert in a patient who has lung injury, emphysema, hemothorax, pneumothorax, hydrothorax, whatever it is. Okay, so this is more easy. With trocar, we just push it in, it goes in. Okay. Can we use this for drain, Arun? Abdominal drains? Why? We can cut it. If we don't have an abdominal drain, this can be used as an abdominal drain. Can we use abdominal drain for ICDs? Why? Ideally, no. But in times of emergencies, clamp one side, push it. We can push it inside and connect it immediately before the air escapes. But ideally, chest drains are supposed to be used for chest drains. Abdominal drains are supposed to be used for abdominal drains. Okay. We connect it to drain bag. What drain bag? Can we connect it to Euro bag? Why? Why? Why is it separate?
Because there is some diameter studies with the filling in the back. It's
Hundred-
column.
So you can connect a Euro bag, connect it to a Euro bag, pour 100 ml saline into it, still you have 100 ml.
No, sir. There is some lines difference with connecting.
ఎవరు చెప్తారు? Who can say that? Huh?
Eurometer with the closest.
I'll tell you. Euro bag తెలియదు కదా? Euro bag is connected with a connector externally. The part in the entire bag is open, whereas in a ICD chest drain tube, you see the middle part here. This middle part is below this 100 ml of saline that will. So there is only one way of going of air from chest into this thing. Air can't go from the water back into the chest, right? So we can monitor air bubbles coming out of this thing. That's one way, and there is no reverse flow. That is the use. That is why we only use this thing. Okay, now. What else do we have? So these are the lines. Next time, what is the ideal time to remove a change of rise tube in a chronically ill patient? If he is at home, if it is in hospital, time period. Ward wall japala. Change of rise tube where when the patient is in hospital, when the patient is at home. No. Days, 14 days, 2 weeks. For a Foley catheter, when the patient is in hospital and when he is at home, 2 weeks. If the patient is sick, will if it's in ICU and all, 10 day or 7 day, depending upon fever, and again if there is discharge and all, we'll change Foley's catheter. If there's any fever and all, we'll change it. Okay, 21 days, very good. Antena, done. Right. Next week, what are we discussing about? Instrument identification, rise tube connection. Major problem what we are facing is about rise tube. Rise tube has to be clamped. Okay, rise tube. One more thing, feeding and aspiration. What is the ideal time to? What is the aspirate that we take after inserting a rise tube? After feeding through rise tube,
So,
after 2 hours, you aspirate, trial aspirate. How much? When do you say? When do you continue with the feed, and when you stop? Hold it before continuing the feeds. So, for example, if the patient has been fed with 100 ml of liquids, okay, you wait for 2 hours and then you aspirate. Okay, so if you have got around 20 ml, what do you do? If you get 70 ml, what you do? If you get 50 ml, what you do?
continue to
Feeds, early feeds.
20 above mean we stop the position.
No. When you aspirate after 2 hours, if it is more than 50% of what you have given, it is reflect. If you are able to aspirate, you don't continue the feed. You wait for 1 more hour and aspirate. Okay. Even after 1 hour, if you continue the same, you don't give it again. So first day when you do trial feeds, if the patient is tolerating or not, you will get to know by this thing. If the patient is tolerating well, you will calculate for the entire day how much is he tolerating. You will give, you will make a quantity of the feed that you are going to give and divide into proportions, second hourly or third hourly, fourth hourly, and feed the patient. Got it? And every feed should be preceded by aspiration, mandatorily aspiration. If you overfeed him, what happens? If you feed more, what happens? Aspiration. Hospital or most common rehospitalization, deaths in hospitals or deaths elsewhere is caused morbidity to the patients is by aspiration, aspirational pneumonia, asphyxia. These are all when patient aspirates. It opens the epiglottis. Then the moment it goes in, his pharyngeal reflex, he'll try to swallow or he'll try to cough it up. He'll try to take a deep breath, it aspirates into the lungs. So this has to be avoided at any point in any hospital. Hi, I'm Dr. Chaitanya, GA and laparoscopic surgeon. Today is day 2 of our clinical teachings about interventions and in lines and catheters that are to be placed in a hospital scenario. We are conducting this class at My Health Hospital. Please, you can pass on the comments regarding your doubts and everything. We'll be glad to help.